Hello, friendly alumni. Welcome back to From Here Forward, an award-winning UBC Podcast Network podcast. I'm Carol.
And I'm Jeevan.
Now, if we go down memory lane, COVID-19 pandemic opened up many doors for telehealth, virtual doctor appointments, telerehab, virtual physiotherapy, and more. And prior to the pandemic, myself included, many of us were probably skeptical of virtual healthcare services.
And I think even now, there are a lot of us who aren't even aware of the different kinds of care you can receive through telehealth services. And for a lot of people, having access to that is really convenient and helpful for folks who aren't able to leave the home or don't have practitioners nearby in their community. And as our guest for today illuminated, one impactful way that telehealth is meeting people where they're at is by supporting folks through stroke recovery and rehabilitation.
Across British Columbia, many stroke survivors, particularly those in rural and remote communities, face an uphill battle when it comes to recovery and rehab. So we sat down with one of the folks in the UBC research ecosystem who are changing that.
We chatted with Dr. Brodie Sakakibara, an associate professor with the Department of Occupational Science and Occupational Therapy, and an investigator at the Center for Chronic Disease Prevention and Management at UBCO.
Brodie leads the Okanagan Stroke Research Lab, where his team is leading innovative, patient-centered clinical trials aimed at making stroke recovery more accessible.
There was lots for us to learn about stroke rehab and prevention, and without further ado, we hope you learned something too.
Great. Okay, so why don't we start off with introducing yourself? Who are you, and what is your occupation/title?
Yeah, sure. So, hi everyone. My name is Brodie Sakakibara. I'm an associate professor at UBC in the Department of Occupational Science and Occupational Therapy. I'm also an investigator at the Center for Chronic Disease Prevention and Management, which is located at UBC Okanagan campus, which is where I'm physically located.
Can you tell us a bit about your work around stroke recovery research? What initially inspired you to pursue that route, and what kinds of work are you doing around it now?
So generally, my overarching research mission is really to improve the recovery of people who have experienced a stroke and empower them to really better manage their long-term health and well-being. And so my work is really with people who have had a stroke with physical, functional, cognitive, communicative challenges and working with them to improve their longer-term health and well-being. And in doing so, I have a couple of research pillars. So my first research pillar is clinical research, and this focuses on chronic disease self-management or self-care, and how people who have had a stroke manage their health and wellness over time. And the second research pillar that I have is on health services, which focuses on telerehabilitation or the delivery of health and rehabilitation services using technology.
Maybe take us back to how you got to this point in your life. You're an undergrad student, you're a graduate student, you're thinking about things. How'd you get here?
Well, if we go way back in the early 2000s, interestingly, I started my undergraduate at what was called Okanagan University College, which is now the UBC Okanagan campus. But then eventually I moved to Vancouver and attended the UBC Vancouver campus. In 2008, I guess it was, I started my graduate training at UBC, where I worked with Dr. Bill Miller, who is now a professor in the Department of Occupational Science and Occupational Therapy. And during this time, I focused on some of the psychological and behavioral aspects of mobility, and specifically self-efficacy or confidence among adults who use wheelchairs for their mobility. After completing my PhD, I pursued postdoctoral training where I worked with Dr. Janice Ng, who's now a professor in the UBC Department of Physical Therapy, and also Dr. Scott Lear, who's a professor in the Faculty of Health Sciences at Simon Fraser University. And in this work, I was exposed to stroke rehabilitation, chronic disease self-management, and also cardiac rehabilitation and telehealth. And following my postdoctoral training, I landed a faculty position at UBC in the Center for Chronic Disease Prevention and Management at the Southern Medical Program, and also affiliated with the Department of Occupational Science and Occupational Therapy. Interestingly, before my graduate training, I thought I was going to pursue a clinical degree. I thought I was going to be a physical therapist or an occupational therapist. And I got an interview to be part of those programs. Fortunately, I wasn't accepted. And then I thought, okay, well, to give myself a better chance chance of being accepted into the clinical program, I thought I would do a Master of Science in Rehabilitation Sciences. And that's what led me to my graduate training with Bill Miller. And then I got exposed to research and developing the evidence that informs clinical practice, and then had the opportunity to do a PhD. And I chose that opportunity and pursued the academic career path rather than the clinical career path.
Super interesting just how things unfold in your career journey. I'm curious about your work with the Okanagan Stroke Research Lab. So can you tell us a bit about what that lab focuses on and what is unique about the work you're doing there?
Yeah, so the Okanagan Stroke Research Lab is actually my lab. Within the lab, I have a couple of postdoctoral fellows, a couple of PhD students, master students, undergraduate trainees, volunteers, and whatnot. And we really work in the two research pillars that I talked about previously. So clinical research, focusing on chronic disease self-management, as well as we have various projects focusing on virtual rehabilitation and telerehabilitation. We started in 2018 and we've been growing slowly but steadily. What I think is unique about our research is that we really focus on secondary prevention after stroke. Part of the issue or concerns about our existing health system is that it's very acute focused. And so if we have stroke symptoms, we go to the emergency, we are transferred to an acute stroke unit, and then many people receive inpatient rehabilitation and then outpatient rehabilitation. After our care within the health system is over, then many people are discharged back home into the community. And as part of our research, we hear time and time again that once people are finished with their services as part of the health system, that they're often forgotten or they feel lost once they're out in the community and they have to sort of fend for themselves. The issue here is that many people will live a long time with the effects of stroke. And so what we see is many of these individuals having secondary events. Around 16% of people will have a secondary stroke within 1 year of their initial event. 1/3 of people who've had a stroke will have another stroke within 5 years. And so it's really, I think, in the chronic setting, once people have returned home and are living back in the communities, that they require substantial amounts of support, but there are few resources for them to access. And so my research really focuses on working with individuals once they're back home and in the community to extend the recovery continuum, and also to work with them on providing them with support and strategies for them to be a key player in their health and for them to manage their health and wellness on their own, which hopefully could prevent secondary events down the road.
I've only been exposed to telehealth and virtual physical therapy, but that's something that I always had skepticism about. Like, is this a thing that will actually help me? I guess my question is, in this point in time, having had this research career, did you ever think that we would be at this point where you would be able to help people through virtual tools like telehealth and telerehab?
Yep, absolutely. I think, technology now is changing everything that we do in ways that, that we probably never really thought about previously, right? And the same is true for health and rehabilitation. Technology is allowing us to connect in ways like through Zoom and through Teams and whatnot, like we've never done before, especially since COVID-19, when there were restrictions and requirements for social and physical distancing. I think this is when really the clinical community really saw the benefits of using technology to connect with their clients and patients. In research, telehealth, telerehabilitation has been around for many years, and we're developing the evidence that it does work, and clients and patients are happy with virtual services. But as I mentioned, really it was COVID-19 that was the catalyst that forced, I guess, the health system to use alternative means of delivering health and rehabilitation, and that was through technology. Post-COVID, the use of technology for delivery of health and rehabilitation has declined, but it's at levels that are still higher than it was pre-COVID. As well, if you take a look at general trends in the research literature, the amounts of virtual health, telehealth research is increasing as well.
Can you talk to us a bit about the difference in access to care in cities, smaller cities versus more rural locations? What are the discrepancies in care, and is that a point of interest for your research?
The access to care is, I would say, different in larger urban centers relative to smaller communities and remote settings. A large part of it has to do with health equity. In larger urban centers, there are more resources for recovery and health services that people can access. Also, the thing about larger urban centers is that's where typically research-intensive universities are located. And it's at these research-intensive universities where new research therapies are being developed and conducting their research. And, they're recruiting individuals in larger urban centers to participate in these studies because that's where they're physically located, right? And so not only are there more general resources available in larger centers than in smaller communities, but there's also the research-intensive universities that are developing these new therapies that people have access to. In smaller communities and rural areas, the number and amount of resources is a fraction, I would say. The other thing is, if you look at our health authorities in BC, the Interior Health Authority, where I'm located with its head office in Kelowna, it serves a vast geographic range in British Columbia. And so while the main hospital, Kelowna General Hospital, is in Kelowna, it serves people from, Revelstoke, Cranbrook, right? 2-3 hours away. And Kelowna, is increasing in size. And so the number of resources is expanding here that people can access. But if we're providing service to people in Revelstoke, for example, and they're being discharged home to Revelstoke, which is a very small community, the resources that they have there that they might require is less.
But if people are in, say, like in a rural location such as Revelstoke, like I would imagine that the recovery would look different from someone, as you said, is in an urban setting. Are there any kind of gaps that your research focuses on to minimize that through telehealth or virtual rehab? Like, does that actually address that challenge for people who are in rural locations?
The telerehabilitation, the virtual rehabilitation, very important for areas like the interior of BC and Interior Health Authority specifically, because we serve such a vast region. People in Revelstoke, as an example. And so I think the use of technology, virtual rehab, to connect individuals, clients who are discharged, who have stroke symptoms and require ongoing rehabilitation with expertise in physical occupational therapists in Kelowna, I think that's one solution to increase the accessibility of the health and rehab services and to make more for an equitable system. The more common challenge that we see in some of our research participants anyway is access to devices, so computers and whatnot, and even having internet plans. They probably have mobile devices like a tablet or a phone, but delivering and receiving rehab services using a small phone or smaller tablet is not as ideal as using a larger screen. This is probably research specific, but for individuals that don't have a computer or internet access, we typically would send them a computer and set them up with internet for the duration of the programs that we offer. And like I said, that's probably research specific. You're probably not going to see that in like a health authority.
We've talked about, management and prevention and recovery, but what are some of generally the challenges, major challenges that you're seeing from stroke survivors in the face of their recovery? Like, what are the common things that come up? Of course, I'm sure there's a range of things that are patient specific, but just for folks who maybe are less in the know.
Yeah. So, when you talk about stroke and secondary prevention of stroke, we have to think about what some of the risk factors are. And, when we think about risk factors, you could categorize them into non-modifiable versus modifiable risk factors. So some of the non-modifiable risk factors are things like age. Stroke is an aging condition, family history, genetics, things like that. You could further categorize the modifiable risk factors into things like health behaviors, so physical activity, diet, nutrition, stress management. And the other category, broader category, would be metabolic risk factors, so things like blood pressure, cholesterol, glucose intolerance, so on and so forth. And if you put these risk factors on a continuum, it's really the health behaviors, I would say, that we have the most control over. Well, what's interesting is that the health behaviors also have a large implication on those metabolic risk factors. So if we are more physically active, if we eat healthier, our cholesterol will probably be lower, our blood pressure will probably be lower, which all contribute to downstream prevention of stroke or stroke onset. Part of the issue with our health system now is that it's like, as I mentioned before, it's very acute focused, right? We have symptoms, we go to the hospital, they keep us alive, we receive rehabilitation and we recover to a level of independence, and then we're discharged home. Part of the issue is that it's all responsive and not proactive for prevention. And what I mean by that is, as I mentioned, 33%, 1/3 of individuals will have a stroke in 5 years for the similar risk factors that contributed to their stroke in the first place. So many individuals will continue living and have health behaviors that contributed to the stroke in the first place because they're not receiving or they don't have ongoing support into the community.
In the last few months, I've been reading a lot about how the different health diseases, illnesses are affecting younger people more than it has before. I'm curious if that's showing up in your stroke research and if that's true in that part of your world.
I don't know the details or the numbers or the literature, but the incidence of younger stroke is increasing. And I think a lot of it has to do with health behaviors. I think younger people might have not as positive activity levels or nutrition habits as our parents or grandparents. And I think that might be contributing to some of the younger strokes that we're seeing for sure.
And just to confirm, the stat of 1/3 in 5 years and 16% in a year of people having a second stroke, is that a high number or is that a okay number? What is that stat emotionally?
I think it's pretty scary. I think, if individuals have had one stroke, you would think that we would provide them and support them as much as we could to prevent them from having another stroke. Secondary events are associated with higher levels of, rehospitalizations, mortality, and morbidity. And at the end of the day, overall larger costs to our health system and our economy. And so, anything that we can do, I think, to prevent secondary events in particular, and even primary events, stroke events are very important.
And, along that line, a bigger picture question, what, in addition to some of the things you've shared, what impact do you hope your research can continue to have on stroke survivors and their families and caregivers as it continues to develop?
So 2 things. One is to extend the continuum of stroke care into the community. So once people have been discharged home, to continue providing them with recovery services so that they can improve their physical and functional abilities. That's through the virtual rehabilitation aspect. The other hope is really to empower individuals themselves to be key players in their longer term health and wellness, and empowering them with the self-management abilities for them to do more things for themselves to maintain longer term health and wellness.
Do you have any surprising stats that you wish people knew about strokes and recovery?
So generally, stroke is a leading cause of disability and mortality in Canada and around the world. After 55 years of age, 1 in 5 people, or 20% of people, will experience a stroke. And in the next 10 to 15 years, it's estimated that nearly 750,000 of Canadians will be living with the effects of stroke. And so the numbers of stroke and people who survive those initial stroke events are increasing. What is good, a good thing, is 83% of individuals who have a stroke will survive, and around 90% of people who have had a stroke and receive rehabilitation will return to community living. And so really the acute numbers, 83% of people who still survive, that's due to medical interventions and doctors and whatnot. That's a great thing. The rehabilitation is great. 90% of people will return home to get to some level of independence that will allow them to get home. But as we've been talking, it's really the chronic phase. I think once people are at home and living in the community where they do receive less support, the numbers are not as great as we talked about. 83% of people will have a secondary event over 5 years.
For any alumni who are listening, who are curious about how to get involved or things that they can do in their day-to-day lives, what words would you have for them?
Okay. So generally, I would say have awareness about stroke, its signs and symptoms, and recovery. Stroke awareness is really important because it can save lives, minimize long-term disability. And so recognizing some of the stroke symptoms early and responding quickly, either for ourselves or friends or family members, can really improve a person's chances of recovery and reducing the severity of lasting effects. And when I say recognizing the symptoms, the Heart and Stroke Foundation of Canada actually has done a really good job of improving awareness about stroke onset. And they have an acronym called FAST, which is face. So is it drooping? Your arms, can you raise both arms? And speech, is it slurred or jumbled? And T is for time. If your face is drooping, if you cannot raise both hands, if you have slurred speech, then call 911 and go to the hospital as soon as possible.
What do you do in your day-to-day life, the environmental stuff that you can control as a stroke researcher to ensure that you are minimizing the stats that we've talked about today?
It's tough. I have to follow more of what I preach. And really what I preach is, the behavioral risk factors, sort of the root foundation of stroke onset and stroke prevention. Because, behaviors are very individual and we have a lot of control over our behaviors and what we do and what we don't do. But, being more active, eating healthier, I think an important one is stress management as well. Getting good sleep quality and sleep quantity, I think are very important. If we don't have proper sleep, then it's really difficult to be more active, right?
Awesome. Well, thank you so much for this insightful conversation. And I will be aware of stroke from now on, and I'll try to keep walking my 10,000 steps. That's what I took from this conversation.
Get those 8 hours.
Yeah, totally.
But is it really 8 hours?
Sleep?
Isn't that like a made up number?
I think it's individual. I think there are recommendations of 8 hours, but it's not only quantity, right? It's quality of sleep. So yeah, I try to get 8 hours and I try to have a good quality sleep.
So Carol, any takeaways from our conversation with Brodie?
So I guess what I really want to say is, I know last month was Stroke Awareness Month here in Canada. And you're like, why are you doing this in July? Don't ask us. It's better late than never, as the theme of today's convos goes. The main takeaway was the stat that he talked about. The 1/3 of people who have had a stroke will have another in 5 years, and 16% will have a secondary stroke within a year. I mean, I know in the conversation, I was like, is that a lot? I don't know. Looking back now, that's a lot. That's crazy.
Well, firstly, yeah, I think that stat is really crazy. And it's just interesting how there are so many things that could happen to you in your life and so many things that you could be doing to kind of help support yourself and like make yourself as healthy as possible in the process. And I realized there's a lot of things that I could be taking a little bit more seriously in my life to help support myself for stroke prevention. And I think it's really cool that there are folks out here doing the work to help make sure that those who have experienced strokes get the support that they need.
I feel like because we're in the era of technology and AI, there's a constant criticism of like, I hate technology, this is bad. But I always forget that technology is still a great tool. Not everyone has access to healthcare services the same way that people like me who lives downtown in a big city does. So that was really cool. Well, stay healthy, folks. Thanks everyone for listening. Make sure you catch our next episode by subscribing or following our show on Spotify, Apple, or wherever you get your podcasts. And if you're feeling your feels, please drop us a review. You can find me on Blue Sky at Carol Eugene Park.
And me on Twitter at Jeevan Sangha. From Here Forward is an alumni UBC podcast produced by Kylie McFedrin for Podium Podcast Company.